Hi there, this is Dr. Mark Donaldson, welcoming you back to the third and final part of our evidence-based challenge, Managing Dental Patients and Anticoagulants. In this final series, we're looking at the practical dental management. What is it that you need to help you manage these patients efficiently and safely on Monday morning? The challenge as practitioners we have is whether or not we want to stop the warfarin or not stop the warfarin perioperatively. If we're thinking about stopping the warfarin, why are we considering that? For how long? When would we reinitiate therapy? Are we challenged because we think that there's going to be difficulty in getting good hemostasis? But if we do stop the warfarin, then we might put our patient at chance or risk of having some type of thromboembolic event. If we're not going to stop the warfarin, again, the challenge is, could the surgical field be harder to see? Will we be able to get good hemostasis postoperatively? And if you take a look at the highest level of evidence, which is a meta-analysis, these questions have been answered for us from the medical literature. In fact, there is about a 1% risk in either category. If we stop the warfarin, there's about a 1% risk of the patient having some type of thromboembolic event, perhaps a stroke, myocardial infarction, pulmonary embolus, and ultimately death. And in the other camp, if we don't stop the warfarin, there's about a 1% chance that we don't get good postoperative hemostasis. Obviously, from this balance, we never stop the warfarin in our patients. Driven by the evidence, of course, Dr. Wall and his group published this article in JADA in 2000, and the highlighted sections again just highlight that 1% risk in either category. Some of the caveats with warfarin: we don't stop the warfarin in our anticoagulated patients. As long as their INR is less than 3.5, almost any type of dentistry can be done. From this chart, we take a look at this therapeutic range of warfarin, understanding again that we would like our patients to be in the 2 to 3 range, or if you have a mechanical valve in situ, anywhere between 2.5 and 3.5. Patients that are under anticoagulated fall into a higher risk category of developing some type of thromboembolic event such as stroke. Patients that are over anticoagulated run the risk of postoperative hemorrhage, bleeding, and perhaps an intracranial hemorrhage. We definitely want our patients to be well controlled before we treat them medically or from a dental perspective. More evidence from JADA 1997, again indicating the INR target range that we shoot for. The second caveat with warfarin is that while we can do any type of dentistry as long as the patient's INR is in the normal range or less than 3.5, if the patient is also taking an antiplatelet agent, then we definitely want to get some type of medical or cardiac consult. Patients that are on both anticoagulants and antiplatelets are definitely in our higher cardiac risk category. Those individuals may require some type of bridging therapy or another intervention perioperatively. And finally, an excellent graph from the Journal of the American Dental Association back in 1997 that uses a stoplight approach to bring all the factors we've discussed together. That is the patient's level of anticoagulation along the x-axis as indicated by their INR, or international normalized ratio, stratified against the type of dental treatment to be performed along the y-axis. Have we made improvements over warfarin or Coumadin? We definitely have some newer anticoagulants. The first, of course, is dabigatran, also known as Pradaxa or Pradax in Canada. Now, this particular agent is a specific reversible direct thrombin inhibitor, or DTI, and it inhibits just a single factor in the complement cascade. If we take a look at our complement cascade again, we can see down in the bottom right how dabigatran has a very specific targeted effect, again, simply on factor 2A. Because of this very specific action, this drug has a very targeted approach. All patients receive anywhere from 75 to 150 milligrams twice a day, depending on their indication. There are no specific lab tests to monitor. But more importantly, from a dental perspective, most dental patients currently taking dabigatran should be stopped 24 hours prior to the procedure, and then the medication can be reinstituted as soon as hemostasis is achieved, typically 24 hours after dental surgery. A second new agent recently released, known as Xarelto or rivaroxaban. This is an inhibitor of platelet activation, fibrin clotting formation. Again, a very targeted, selective, and reversible inhibition of a single factor in the clotting cascade, and that is 10A. Referring back to our clotting cascade then, we can see where rivaroxaban inhibits 10A. And once again, with this very specific targeted approach and a half-life of less than 12 hours, all patients, regardless of age, weight, anticoagulation status, other than indication, will receive a dose between 10 and 20 milligrams daily or twice a day. Similar to Pradaxa, for most patients undergoing dental procedures, rivaroxaban can be stopped about 24 hours prior to dental procedure and then reinstituted about 24 hours after dental surgery as soon as good hemostasis is achieved. Finally, the third of the newer anticoagulants is known as apixaban, or Eliquis. It inhibits platelet activation similar to rivaroxaban in the sense that it selectively and reversibly inhibits factor 10A. Here again is our clotting cascade, and similar to rivaroxaban, apixaban focuses on a single specific factor in the complement cascade. This drug also has no specific lab tests, no international normalized ratio or INR to monitor. Patients receive a standardized dose anywhere from 2.5 to 5 milligrams twice a day, depending on their indication. And similar to the other two newer agents, the drug should be stopped 24 hours prior to the dental procedure and reinstituted as soon as possible after dentistry. Typically, that's 24 hours or once good hemostasis is achieved. In terms of general dental management then, even after all of these excellent pharmacological measures are taken into account, if you still get that call after hours from a patient saying they're still having trouble with bleeding issues, not clotting appropriately, we can always ask them to bite on a wet tea bag. Again, not just the pressure, but the tannic acid acts as a good hemostatic agent. More than likely, these individuals should be seen either immediately in your office, or you can meet them at the emergency department to look into the situation further. To close out this section then, as far as hemostatic agents, in addition to pressure, suturing, which we've seen, there are some pharmacological interventions with gel foam, Surgicel, bone wax, tranexamic acid, and topical thrombin. And with regards to some of these topical thrombin agents, I've included this chart for completeness in the study, and I would draw your attention to the thrombostat indication and features. How potent is this particular intervention? Well, one 5,000 unit vial dissolved in 5 milliliters of saline solution can clot an equal amount of blood in less than 1 second. Definitely useful for severe bleeding, while not necessarily in all patients. Again, starts to really mitigate that 1% risk of patients whom we keep on warfarin therapy but are still not able to get good hemostasis post-operatively. At the end of the day, following the current guidelines and evidence from the dental literature, we'll be successful in managing all of our anticoagulation patients. And if we stay ahead of this, we won't be too surprised by anything that could possibly sneak up behind us. Thank you again for your time today.